So, good morning, all. Welcome to this fifth National Pharmacovigilance Week, being hosted by ADR Monitoring Center, Department of Pharmacy Practice, ISF College of Pharmacy. I, Dr. Saurabh Kose, would like to welcome to all the participants. I would like to welcome our worthy director, Professor G.D. Gupta, sir, IQAC coordinator, Dr. Siddharth Mehan, all HODs and dear participants. It is a matter of pride and privilege. Today, we have a very expert speaker with us on day 5. And today we have, ladies and gentlemen, Dr. Rimpi Arora. She is working as clinical pharmacologist in Department of Clinical Hematology, Christian Medical College and Hospital, Ludhiana. Dr. Rimpi Arora is a veteran pharmacologist in field of research, academics, administration, and clinical research operations, management of medications. NABS, JCI accreditations are the core expertise of Dr. Rimpi Arora. Madam, we would like to welcome you from ISF College of Pharmacy. And before starting, I would like to invite Professor G.D. Gupta, sir, for a couple of minutes for words of blessings to all the participants. Please, sir.
So, thank you very much, Dr. Koseji. On behalf of ISF College of Pharmacy and Department of Pharmacy Practice, first of all, I welcome Dr. Rimpi Arora ji on this occasion of the fifth pharmacovigilance. We are going to the organizing of this week. So, as we know that during these week, number of the speakers they have the deliver the lectures, and we have the MOU with the CMC, and one of the dynamic dedicated Dr. Rimpi Arora ji, she is working is there, and number of students they are the working under the supervision of the Dr. Rimpi Arora ji. So first of all, I welcome you, madam, from core of my hearts, and I am
Thank you,
thankful
sir.
to the whole of the team of your CMC for providing this opportunity to our student and always dedicated for the profession of the health. So I hope that in the coming days we will do the number of the joint efforts so that it will be the helpful to the society as well as the peoples those are who are connected with the health profession. So thank you very much for accepting our invitation without any taking time. I again thankful to you, and I am thankful to the whole of the team for providing this opportunity to our student and always dedicated for the profession of the health. So
Hello.
Yes, ma'am. Wait a while.
Okay.
Okay, ma'am. So, sir, have perhaps some technical errors over there.
Okay.
So,
yeah, yeah,
sir
yeah.
has joined. Sir has joined. Yes, sir.
Okay, so okay, no problem. Please proceed, Koseji, due to the net connection. So thank you very much, Dr. Rimpiji, and again welcome you. Please proceed.
Thank you. Thank
Thank
you,
you,
sir.
sir.
Thank you. Thank you,
And
sir.
without taking much time, I now would like to call Dr. M.P. Arora, madam. All digital dias is yours, ma'am. Please start your presentation, and the participants will be beneficial. And I request all the participants to be patient. Do not open your mic in between. And at the end of the session, we will take question. You can type the questions in the chat box. So please, ma'am, proceed. Start.
Thank you. Thank you, sir. First of all, good morning to all of you, and congratulate for organizing such event, and that is themed on the pharmacovigilance. And thank you, Principal Sir, Dr. G.D. Gupta, Vice Principal Sir, Dr. Naran, and all the HODs of respective departments from ISFCP, especially the HOD Dr. Kosi sir of pharmacy practice, and head of the IQAC committee, Dr. Siddharth Mehan, and all the students and dignitaries present here for this lecture. Thank you for giving me such a great opportunity. And firstly, I would like to introduce a little bit about myself. I, Dr. Imbi, working as a clinical pharmacologist in the Department of Clinical Hematology, Bone Marrow Transplant Unit, with the supervision of Dr. Joseph John at Christian Medical College and Hospital, Ludhiana. And today I'm going to present one of the relevant topic on the theme of pharmacovigilance, that is the role of pharmacovigilance in antimicrobial resistance and rational drug use. Means how the pharmacovigilance related to, or how the pharmacovigilance cope up the rational use of drug and antimicrobial resistance preventions. Firstly, we will discuss about the pharmacovigilance, then we will discuss the rational use of the drug and how pharmacovigilance and rational use of drug can prevent the antimicrobial resistance to preserve our antibiotic antimicrobial for our future generations. Going forwards, uh, firstly, we will discuss the meaning of pharmacovigilance. As like other vigilance, vigilance means to watch out and to make attentiveness and to be alert. And it is related to pharmacovigilance means vigilance of a pharmacon. Pharmacon stands for drug, and vigilance means a continuation monitoring as well as watch and alertness as well as attentiveness for the pharmacon means the drug. Basically, it deals with the science of detecting, assessing, understanding, and preventing ADR. So, firstly, we will discuss the term ADR, how it differentiates from ADE. As we already know, there are two different terms and two different aspects related to ADRs. One is ADE and one is ADR. As we know, if the drug is responsible for any unwanted response after taking the drug, that is known as ADE, until or unless it is confirmed that that particular reaction is due to the drug only, until or unless it is only the ADE. And most commonly, we report AE in the clinical trials only. And if we confirm after taking the drug reaction, if that particular reaction is due to the drug only, then we can report as a ADR. Or in simple terms, you can say if there is a any unwanted reactions due to the drug at a standard dose, then it is known as ADR. Otherwise, it is known as ADE. For example, if we are taking paracetamol and in the next day you observe the cold or any allergic reaction due to drug paracetamol, and it is ADE until or unless it is not confirmed it is due to the paracetamol. Okay, and after it is confirmed due to the paracetamol, then it is come under the category of ADRs. Next, we will discuss about the antimicrobial resistance. Antimicrobial resistance itself name indicates that resistant towards the antimicrobial agents. It may be antibiotic, antiviral, or antifungal agents. Means the resistance against the agent that are we used for the treatment of microbial infections. For example, antibiotic like penicillin, we generally used antibiotic or most commonly used antibiotic, that is the penicillin, that is effective against most of the microorganism, but recent days it is showing resistance against some of the strains of bacteria due to some other reason or due to some challenges that we will discuss in this lecture or later on. And after that we will discuss how pharmacovigilance and pharma means antimicrobial resistance and rational use of antimicrobial agents linked with each other, and how the pharmacovigilance team can assist, can detect the pharmacovigilance or any of the rational use, irrational use of the drug related to antimicrobial resistance, and how we can prevent the antimicrobial resistance. So, firstly, we will discuss antimicrobial resistance and its global threat. in the recent data of 2022 published in Lancet, it discussed about the drug resistance or antimicrobial resistance of responsible for 5 million deaths worldwide. And it is the data that is means taken from 2019 till 2022. And in the recent data in 2022, same data published in Lancet, and it has been discussed that the 4.7 million death, it is due to the antimicrobial resistance. And how this resistance due to the pharmacovigilance can be decreased, can be reduced. And first we will discuss the antimicrobial resistance, what would be the causes for antimicrobial resistance, and what would be the consequences for antimicrobial resistance. Taking one of the example, for example, if the person is suffering from viral infections and we are using the antibiotic, there is no rationale of antibacterial agent, there is no rationale of antibiotic for viral infections, because the infection causing agent, it's the viral organism, and we can't use antibiotic for the viral infection. Irrespective, we have to prefer antiviral agents for the viral infection. In the recent scenario, we are having sore throat, and we are means in the current practice or in the usual practice, we will give the antibiotic without confirming it is antifungal, means it is a fungal infection, it is a viral infection, or is it a bacterial infection. And particularly under the bacterial infection, which microorganism is responsible for infection? Is it a staphylococcal, aureus staphylococcus, any other strain of staphylococcus? Then we can go for bacterial infection. Otherwise, we will go for antiviral agents. Second most causes for antimicrobial resistance, that it is the overuse of prolonged as well as broad spectrum antibiotic use, means the prolonged use of broad spectrum antibiotic use. In the usual practice, we will prefer the antibiotic use up to 7 days to the max, means 3 to 7 days we can use the antibiotic. After the 7 days, we have to de-escalate or escalate the antibiotic. Otherwise, we have to withdraw the antibiotics. Means not prefer to use the antibiotic either. Any of the means microorganism is responsible for the bacterial infections. So if we are using the means a prolonged use of bacterial agent or antimicrobial agent, that is responsible for antimicrobial resistance. Next one, poor infection control. Poor infection control, if consider we are giving antibiotic agents, and after the 3 days we are taking the culture reports, and we means when there is a presence of culture report and there is a particular resistance against that particular bacteria, but we are recommending the same antibiotic in that particular bacterial agents or bacterial infection, and that is responsible for poor infections control. Means we are giving the antibiotic against, not against that particular microorganism, but irrational to that particular microorganism, and that is responsible for different type of resistance. First example, extensively drug resistant TB is very difficult, and that is responsible for either the means difficulty to treat that particular infection, or there is an ignorance, or there is a no effect on that particular microorganism. And how the PV team, means pharmacovigilance team, responsible for rational use and of antimicrobial agent as well as the prevention of antimicrobial resistance. There are total 7 hours for rational use of antimicrobial agents, but irrespective means with respect to the antimicrobial resistance and rational use of antimicrobial agents through pharmacovigilance or at the desk of pharmacovigilance, there are total 5 hours. Firstly, the right patient, then the right drug, then the right dose, right duration, and right route. Apart from these 5 hours, we can include right time and right monitoring. Apart from these 5 rights, and these 5 rights means if we are taking any patient history, we have, or if we are going to prescribe any antimicrobial agent, first we have to identify the patient. Is it the right patient to whom we are going to administer any antimicrobial agents, that is known as invalidations. Next is consider age. When we are going to file any case of any particular patient, we have to visualize the two correct are, one is the correct patient with the name as well as with the date of birth, and the third most, if the patient is having same age, same date of birth, and we have to analyze the right, his or her father name or mother name. That is the criteria for invalidations of the patient. Next one, the considering the age. If the person is the same, then we would go for the age. Next, we will analyze the comorbidities, means if the patient is suffering from any other type of disease, for example hypertension, for example any renal impairment, and any allergic syndromes and any allergic reactions in the patient initials assessment form. That is the right patient. After that, we will go for culture reports. If the patient is means admitted for the first time, then we will go for empirical therapy, means the therapy that is based on the standard care of treatment. After that, we will go for the culture report. Culture report means if the patient is having any means bacterial infection or viral infection or fungal infection, and if the patient is suffering from bacterial infection, then we will go for culture report. If the then we will go for, if the culture is positive or negative, then we will proceed accordingly, means the standard care of treatment will change accordingly. Then we will check the right route, either it is the right route for drug administration or not, right duration, right dose, correct strength, for example amoxicillin, right drug, for example oral vancomycin instead of IV vancomycin, if the person suffering from febrile neutropenia with no clostridium difficile. I would like to explain in detail. For example, if the person is means the person is suffering from renal impairment, I am taking the example of posaconazole. If the patient is suffering from renal impairment, the dose, standard dose of posaconazole is 300 mg. If the person is suffering from renal impairment, the posaconazole dose should be reduced till 100 mg once a day. Otherwise, the standard dose of posaconazole is 300 mg twice a day. Then we will go for a right route. As already mentioned here, oral vancomycin started instead of IV vancomycin. If the person is suffering from febrile neutropenia with Clostridium difficile, then we will go for oral vancomycin. Otherwise, it will prefer, that is, we have to use IV vancomycin. Right duration, as I already mentioned, that the antibiotic course should be 3 to 7 days, and for an average 5 to 7 days is enough for the antibacterial therapy or antimicrobial therapy. And if it is a critical condition, for example the patient is in bone marrow transplant unit, then we can go for more than 7 days therapy for any of the antimicrobial agent, either antiviral, antifungal, or antibacterial. But if the patient is not a critical condition, then we will prefer to de-escalate, either de-escalate or withdraw the antimicrobial agents. Next is the right dose. Right dose means if we are giving amoxicillin 500 mg, it is a TDS, means twice a day. Otherwise, means if we are giving any of the means dose that is not up to the mark, it will responsible for drug resistance and as well as any ADR means in the patient. For example, there is a one patient that is means we are giving the means we were giving the dose of vancomycin 350 mg as a standard dose. But if the patient means is of 20 kg weight, means a right dose means if the patient is having different means weight criteria. Correct strength or correct dose means the standard dose of vancomycin is 360 mg per kg, and if the patient is per kg, means we consider 70 kg as a standard dose, as a standard weight, and we will prefer vancomycin 360 mg for the standard 70 kg. And if the patient is having 20 kg weight, then we have to adjust the weight of the strength as well as the dose of the drug, means vancomycin, accordingly. If we are taking or we are giving the 360 mg vancomycin per kg, means per 70 kg, we have to reduce the dose for that particular weight. Means if we are considering 20 kg, we have to reduce the dose of vancomycin till 20 mg or 15 mg as per the weight of the patient. That is the right dose or right strength. Similarly, we have to adjust the drop rate and frequency rate. For example, if we are talking about the vancomycin, most of the person who are administered with vancomycin is responsible for red man syndrome. And the standard dose of vancomycin, as I already explained, but there is a accurate infusion rate, means we have to administer the vancomycin over 60 minutes. And if we are increasing the infusion rate or if we are decreasing the infusion rate, it will be responsible for any of the adverse event and any of the microbial resistance. And here we are talking about the vancomycin. It is responsible for, means the red man syndrome. And if we are increasing the frequency of vancomycin through IV route, it is responsible for red man syndromes, and it will happen in any of the patient, and it will reported as a ADR. And being a pharmacologist or being a pharmacist, we have to means monitor these kind of small error to prevent ADR as well as antimicrobial resistance. And this is the right drug for right patient. If we are giving the means we are using the vancomycin for febrile neutropenia. Firstly, we means what do you mean by febrile neutropenia? The patient that is suffering from Clostridium difficile or any of the means bacterial infection, or any of means any of the patient of a bone marrow transplant, means the person that is undergone in the transplant procedure, that is responsible for decreased level of neutrophils less than 1500, and that condition is known as febrile neutropenia. And if the person is suffering from Clostridium difficile, it will responsible for, means change of route of vancomycin. If there is a Clostridium difficile, then we will go for IV vancomycin. If there is no Clostridium difficile, then we will go for oral vancomycin. And how the pharmacovigilance and how any of the pharmacovigilance team, means the team that is responsible for ADR, means adverse drug reactions report, how it is responsible for rational use of drug, that is I already explained the previous slide. And how the pharmacovigilance team responsible for prevention of antimicrobial resistance. The pharmacovigilance team detect ADRs, it is in actual ADRs or due to the medication error. As I already explained, the vancomycin is responsible for one of the serious ADR, that is red man syndrome. But it is due to the vancomycin, or is it due to the infusion rate, that we have to analyze, we have to monitor. Or PV detect ADR, prevent unsafe use of or unsafe drug use. Example, ADR monitoring reveal fluoroquinolones causing tendon rupture, FDA issues warning restricted use. One of the another example, fluoroquinolones. We have to, means we administer fluoroquinolone in any of the patient, and it is responsible for tendon rupture. And because of means fluoroquinolones, it is again an infusion rate responsible ADR. Fluoroquinolones have to administer 30 at the rate of 30 to 60 minutes of duration. And if it is a response means if the infusion rate of fluoroquinolones administration increase more than the normal infusion rate, it is responsible for tendon rupture. And it was detected by the pharmacovigilance team, that is the infusion rate increased from more than 60 to 90 minutes, it is responsible for tendon rupture. And due to that, FDA issued some warnings, that is the fluoroquinolones should be restricted, means unless or until it is responsible for a critical condition, we can't recommend the fluoroquinolones. Similarly, the pharmacovigilance team monitor the prescription trend. For example, normal means clinical practice, ceftriaxone, it is overused in the hospital, and it is responsible for many of the area that is responsible for antimicrobial resistance. And that's why pharmacovigilance team monitor if there is a overuse of ceftriaxone, it is responsible for flag of audit team, means we have to restrict the overuse of ceftriaxone in a normal hospital practice. Next, that is the pharmacovigilance data can guide stewardship policy. And next, I will explain the stewardship policy with one of the RFO. Basically, what do you mean by stewardship policy? That is, word stewardship means the responsible management. That is that we used to observe in any of the clinical practice, in any of the academic practice, means responsible management of any of the process, that is known as stewardship. And here we are discussing about the antimicrobial resistance, means the antimicrobial stewardship policies, means the responsible management of antimicrobial. And here we are conducting PPSC, means a point prevalence survey, that is the observation, or it is a kind of audit, that is we observe the use of antibiotic in whole of the hospital at a single point, means within the 24 hours we have to analyze, or we have to review all the chart during the 24 hours duration, means which patient is on which antibiotic from how many duration, means what would be the start time, what would be the time out of antibiotic. Then I will explain this stewardship in detail by using PPSC form after explaining all these slide. But here the pharmacovigilance team responsible for the rational use of a antibiotic for a particular antibiotic. For example, during the chart review, if the person is using the antibiotic, any of the antibiotic more than 7 days, that is our responsibility to give a flag to the clinical team to prevent either to prevent or de-escalate the particular antimicrobial agents. Next, that is the tool for pharmacovigilance, that is responsible for prevention as well as a reduction of antimicrobial resistance. For the first one, that is the spontaneous reporting system. For example, we already know the colistin is responsible for nephrotoxicity, and if the person or if any of the medical person, means a clinical team, any of the physician, any of the consultant or DM resident, or any of the team member of medical using the colistin in any of the patient with already renal impairment, that we have to report on in a spontaneous manner to prevent the use of colistin, that is as per the strict dosing guidelines. Next one, the hospital based monitoring, means in the chart round or ward rounds, we have to monitor the area, and we have to match that monitoring with the standard guidelines. And we have to means recommend to the means clean treating clinicians, means to have to follow the hospital based guidelines to prevent the antimicrobial resistance as well as rational use of the drug. Second, and the third one, the electronic health record maintenance. If there is a means during the audit process of electronic health record, means if we are giving the antibiotic or any of the antimicrobial agent, that has to be recorded electronically as well as in the physical record, means MRD, means medical record, that is the physical form of any patient. And at the same time, we have to record those prescription in the electronic software. Here we are using the HIMS software that we use to maintain the record of prescription of any of the antimicrobial agent or any of the prescription of that particular patient. And in that particular electronic health record audit, if we observe the patient is on broad spectrum antibiotic, for example meropenem or vancomycin. As we already know, meropenem and vancomycin are come under the category of restricted antimicrobial from the WHO, as per the aware category of WHO. Aware category of WHO means there are certain there are three categories of antibiotic by the WHO. One is excess antibiotic that we can use frequently, means over the counter antibiotic, means without any prescription. Next is the watch means if we are administering that antibiotic, we have to continuous monitoring of that particular patient lab results as well as any of the reaction to prevent any of the ADR or any of the AE. And the third category of aware, that is a restricted antibiotic, means we can't use those antibiotic without any of the prescription or many of the consultations, and without any of the microbial confirmation, means we can use meropenem or vancomycin if there is a critical need of that particular restricted antibiotic. So during the prescription audit in the electronic health record system or as well as the medical report audit, we had to generate the flag or to that particular consultant or any of the team member of the treating clinic treating patient, means these are the category of excess, these are the category of watch antibiotic, and these are the particular restricted antibiotic that have to be used with precaution, or we have to be used that particular antibiotic under monitoring, and these are the restricted antibiotic that we can't use without consultation or without microbial confirmation. And these are the tools for pharmacovigilance for prevention of antimicrobial resistance. If, for example, we are restricting the use of meropenem and vancomycin under critical conditions, so obviously we are preventing the use. Firstly, we are preserving the antimicrobial agents for our future generation, and at the same time we are preventing the resistance of that particular microorganisms against which the meropenem or vancomycin or any of the restricted antimicrobial agents that we are using against that particular microorganism. And these are some case examples that are related to the pharmacovigilance, as well as a tool for pharmacovigilance to prevent the antimicrobial resistance. As I already explained, fluoroquinolones are responsible for tendon rupturing, and it has been warned by the pharmacovigilance team. And after the warning by pharmacovigilance as a reporting of ADR as tendon rupturing in any of the patient, that is responsible for warning to the WHO as well as the Europe FDA to be preserved fluoroquinolones in the black box. Means there is some means a high alert medication that we have to preserve in the black box under the supervision of medical superintendent or the clinical team, that if we are using that particular drug in a ward in for the inpatient use. And if we are using the same drug in a pharmacy, that same box we have to preserve under the category of or under the supervision of a registered pharmacist only. Next, the cholesterol resistance PV data and microbial surveillance helps to restrict the use of cholesterol under the critical condition, means the intensive care units, but restricted only. Next is another example, line solid, that is we particularly used for meropenem, methicillin resistance as well as vancomycin resistance, anti any of the infection that is resistant to methicillin and vancomycin, particularly means the diphtheриal infection. In that particular case we use linezolid, and again the linezolid have certain safety alerts, ADR reports too, that means some of the ADRs reports that linezolid is responsible for bone marrow suppression. And if we are using the linezolid in case of methicillin resistance, staphylococcus aureus, and as well as vancomycin resistance, staphylococcus aureus, we have to go for linezolid. But if we are going for linezolid, it is responsible for bone marrow suppression as well as optic neuropathy. And if we are giving any of the means linezolid in any of the methicillin resistance as well as vancomycin resistant staphylococcal aureus, we have to observe bone marrow suppression as well as optical neuropathy, means if there is a visual disturbance in that particular patient, or if there is a decreased level of our neutrophils. And if we are using linezolid, similarly we have to restrict the linezolid less than 14 days. And in continuation we have to measure the blood count as well as the vision changes. That is the means guidelines for using linezolid as a safety alert to prevent any of the ADRs or to prevent the resistance against the linezolid. Okay. And as I already explained, it is used in methicillin resistance MRSA, methicillin resistant staphylococcal aureus, as well as if there is a resistance against methicillin resist means we have to go for vancomycin. Similarly, if we observe resistance against vancomycin, then we can go for linezolid. And if we are using linezolid more than 14 days, there will be a possibility for resistance against linezolid. And we means can't afford any of the means resistance against any of the microbial antimicrobial agent for any of the microorganism. Means we are already resistant with the methicillin, means the staphylococcal aureus showing resistance against the methicillin, we have to change the therapy for vancomycin. And in case of vancomycin resistance, we change the therapy from vancomycin to linezolid. If in case we observe the same cases of resistance against the linezolid, we have to change the therapy against another or against new antimicrobial agents. So there is no preservations of antimicrobial agents for our future generation. And similarly, as ADR reporting team or pharmacovigilance team, we have to focus on the rational use of the antimicrobial agents to prevent the antimicrobial resistance, not only for the safety or of infection, but for the safety of the patient and preservation of our antimicrobial agents for the future generations too. And this is in a nutshell pharmacovigilance as well as a rational use of drug support evidence based prescribing. As I already explained, when the patient enter into the hospital, we have to go for empirical therapy as well as evidence based therapy. Empirical therapy means the person started the treatment, means the treating physician started the treatment based on his or her observation. And next is evidence based prescription, that is we firstly go for the culture report, then we can start for that particular antimicrobial agents. Means if the person is suffering from antiviral agent, we can't go for antimicrobial agents, antibiotic agents. So we can prevent the means firstly we will use the rational we can prefer the rational use, then we will go for the uh, prevention of antimicrobial resistance. For example, in the malarial treatment, PV data shows the chloroquine of failure. If there is a chloroquine failure, then we can go for artemisinin based combination therapy. If there is a means the microorganism Plasmodium ovale or Plasmodium falciparum is still showing effectiveness against a chloroquine, we can go for chloroquine. Otherwise, we can go for ACT, means artemisinin based combination therapy. For example, if the patient is suffering from sore throat, we can go for the means mild acting antibiotic, but in the usual practice, we will go for azithromycin. Thus, at some extent, it will be responsible for creating resistance for azithromycin too. So firstly, if the patient means if the means you are observing any of the patient with any of the infection, firstly go for evidence based therapy, means we have to prefer culture report, then we have to start the therapy based on the culture report positiveness. Mean if the patient is not suffering from any of the bacterial infection, then there is a waste of that particular antibiotic agents. Similarly, means we have to educate the clinician for safe use of the drug. For example, clozapine, it is an antipsychotic agent and it is responsible for life-threatening agranulocytosis. Agranulocytosis means drop of white blood cells. And if we are using clozapine as an antipsychotic agent, then we have to educate the clinician. It is responsible for agranulocytosis and it is responsible for life threatening, it is a life threatening condition and we can prevent the clozapine in a similar manner. And it is a response, means it is not an antibacterial agent, antimicrobial agent, but we can educate the clinician in the same manner. If we are means if any of the clinician using the antibiotic or antimicrobial agent irrelevant to the uh, culture report or irrelevant to the infection of that particular patient. Next, Indians Pharmacovigilance Reporting Center in India to prevent the antimicrobial resistance. ADR monitoring centers collect the antibiotic related ADRs. Means if we are means filling the ADRs, means adverse drug reporting data. Firstly, we have to observe the root cause analysis. Means the actual ADR, it is due to the drug only or due to the medication error or due to the clinician error or any of the monitoring error. For example, the patient is suffering from if we are administered teicoplanin. Similarly, means as like vancomycin, teicoplanin is responsible for Redman syndrome. The same cause infusion rate. This is the actual example of CMC. We administer, means any of the means administering sister or a ward in charge has administered a teicoplanin to an means one of the patient, and it is responsible for Redman syndrome, means a sudden itching as well as redness of the body. And after root cause analysis, what we have observed, that is the infusion rate is less than or less than means 30 minutes. That is responsible for itching type of syndrome in that particular patient. Similarly, means if the means a pharmacovigilance reporting center, carbapenem induces seizures, improving safe prescribing. That is another case. Carbapenem is responsible for seizure. And what would be the cause of carbapenem in it? Is it the carbapenem is responsible for seizure, or it is the drug or frequency or the dose route is responsible for carbapenem induced seizure? If we are means prescribing the exact dose but not the means following the guidelines for proper administration of any of the drug, that is responsible for ADR. But before reporting of the ADR, we have to analyze the root cause analysis. Means of the 5R that I already explained. Is it the right patient? Is it the correct age? Is it the correct dose or right route or right route of administration, right frequency? We have to monitor all these parameters. That is responsible for means prevention of antimicrobial resistance as a PVR or as a ADR reporting team. And most of the ADR reporting centers are has been linked with the national authorities to take an action plan to prevent the antimicrobial resistance and to support the antimicrobial resistance to through the anti ADR reportings or ADR monitoring. And these are the some future direction. Means as we already know, all of the means channels has been linked with the AI, artificial intelligence, and that is quite obviously responsible for early detection of ADR, as well as another future direction that is responsible for farm as like VG there are certain global collaboration via WHO, that is through VG base, that is responsible for ADR reporting, ADR monitoring, and to prevent the pharmacovigilance. Next is the patient reporting apps like India PVPI. There are means certain other reporting apps that we can use for reporting of the ADR. That is actually due to the microbial agent, and expanding this pharmacovigilance to veterinary antibiotics. Similarly, means if the antibiotic we are using for the human being, antibiotics are using in the veterinary practice. And similarly, means if we are using reporting of ADRs in human beings, we have responsibility to report the ADR if we are observing same kind of ADR in the veterinary practice too. To conclude this session, pharmacovigilance is a vital in combating the antimicrobial resistance through rational use as well as complete monitoring and actual reporting of ADR if it is related to the drug, not due to the dosing errors, not due to the frequency errors, or any of the cause that is not directly linked to the drug or drug dose, and ensure rational drug use as well as safety of the drug. Drug driven policies improve the outcomes. If there is a drug responsible for from ADR, we have to manage our data, and we have to make certain policy to report that data to improve future outcomes to prevent the antimicrobial resistance. And we have to integrate pharmacovigilance with the antimicrobial resistance program to prevent the antimicrobial resistance, to improve the pharmacovigilance, to decrease the ADR, and to prevent the antimicrobial resistance, and to preserve our antibiotic or antimicrobial agents for our future generations. And thank you for to all the organizer and the audience, and you can contact me at below mentioned ID. Before closing this session, I would like to share one of the link that I already mentioned in my presentation, that is the PPSC. Is it visible?
No, ma'am. It's a video.
No. It's a R4.
You have to select the window, ma'am. First, you have to. Yeah, now it is visible, ma'am.
Okay.
Now visible.
So going towards the PPSC means one of the parameter, that is a point prevalence survey, that is used to prevent antimicrobial resistance, and that is to be done by the PV team, means pharmacovigilance team. Here we have to check the patient, means for whole of the patient, means through chart review, which means patient is on which antibiotic, from how many duration or from how many days. And this is the R form that is we use to for point prevalence survey. This is about the basic information, patient information. This is the auditor name. For example, I am going to do the hello. Employer or auditor name. Here we have to fill the unique hospital ID that I already mentioned. Ward or unit, for example, Ward 26. Specialty, Ward 26 belong to which particular department, for example, BMT, bone marrow transplant. And here, date of birth we have to mention. For example, 9925. Age, male, it means age depend upon the date of birth, it's been already calculated, male or female. Weight we have to write down, for example 20. Diagnosis, for example ALL, means acute lymphoid leukemia. If the person is having any of the comorbidities, we have to note down that is mellitus, hypertension, or any of that comorbidities. Date of admission, for example, today the patient has been admitted, and this is the date of audit. If we are changing the date of admission of the patient, for example 14, and the length of stay, it's been already calculated automatically. Next we have to go for surgical prophylaxis. As I already said, we have to go for empirical therapy or evidence based therapy. But in the surgical prophylaxis, we have to administer antibiotic within the 24 hours of the surgical prophylaxis. Surgical prophylaxis has been done or no. If there is no done, there is no prophylaxis, we have to enter no. If there is a surgical prophylaxis has been done, then we have to click on the yes. And name of the surgery, for example, if the patient is pediatric, then we have to enter the name of the surgery, pediatric. Then is it a planned or emergency? If there is a emergency, then we have to click on the emergency. If there is a planned surgery, for example, if the person is in bone marrow transplant, we have to means that we have a planned surgery. Otherwise, if the patient is coming under the category of casualty, we have to enter into the emergency. And we have to enter cleaned or contaminated. Before the surgery, we have to observe the site of the surgery. Is it free from microorganism? Then we have to note it down the clean. If it is clean and contaminated, means the site of surgery, we have to observe, is it is there any wound or not? Then we have to proceed accordingly. Then if there is any culture report or any biomarker that been already done or not, we have to note it down the data. For example, culture or laboratory details. Then if there is no culture report sent, then we have to enter no. If there is a culture report already been sent, we have to enter the data as yes. Culture report sent on which date? For example, the patient has been admitted on 14. Culture report sent on 15. Within 24 hours, culture report means issued on 16. Culture site, blood, urine, respiratory or other. If we are discussing about the surgical prophylaxis, then we have to move accordingly. Otherwise, we have to go for blood culture. We can enter the culture report. So as many as, it means, for example, the person is suffering from respiratory tract infection. If there is infection in blood, if there is infection in urine, we have to proceed accordingly. And at the same time, we can enter blood, urine or respiratory report at the same time. If the culture mention any other culture, if we are selecting here other, positive culture, for example, after the culture report there is a bacteria, that is Klebsiella pneumonia is positive. Then we have to note down the total leukocyte count, CRP, creatinine, reactive protein, any of the other biomarker we have to note it down. Then we have to go for, if the patient is on antimicrobial agent based on the empirical therapy, yes. If there is no antimicrobial agent, then we have to click on the no. And if there is a antimicrobial agent based on the empirical therapy, means based on the observation therapy, we have to collect that data. Was the antibiotic written or not? Yes or no? Then risk category of patient based on the pharmacovigilance, the risk category of patient has been categorized into four category. For there are certain four category: patient category 1, 2, 3, based on the exposure of the antibiotic. Means if there is a prior exposure of antibiotic, prior exposure of hospital, prior exposure of antibiotic as well as hospital, or if there is a critical condition of the patient, then it is goes towards the category of risk category. Possible site of infection, for example, patient is suffering from Klebsiella pneumonia, then it is a respiratory tract infection. number of antibiotic on audit day. For example, if we are clicking on antibiotic on means 1, then there is a drop down of antibiotic for that particular antimicrobial agent. If we are clicking, if the patient is on category antimicrobial agents 2, then there are drop down for those 2 antimicrobial agents. For example, if the patient is on 1 antimicrobial agent, then we have to note down which antibiotic is used against that particular infection. Okay. For example, amoxicillin, and it will automatically link with the category of that particular drug. For example, amoxicillin, it belongs to antibiotic classification beta lactam antibiotic, and as per the WHO category, it belongs to excess category. And if we are clicking on any of the restricted antibiotic, for example, meropenem, methicillin, or for example, meropenem, it will automatically get linked with the WHO watch category. Then valcyclover, there is no means category as per the WHO, but it belongs to antiviral agent classification. Then we have to belongs, click on route of administration, indication type, empirical evidence based, anti or any of the surgical prophylaxis, dose has what dose has been administered for that particular patient, antimicrobial agent. For example, 1500 mg. Then after the culture report, antimicrobial reviewed or not. If reviewed, what was the action taken? If the dose is escalated, de-escalated, continue, or stop, we have to note down that means parameters. And this is the data that been already collected for our previous PPSC, and this is the analysis part. Means the number of patients on antimicrobial agents, on 0 antibiotic, on 1 antibiotic, on 2 antibiotic, and so on. Number or percentage of the antibiotic means antibiotic for means against which culture has been sent or not. Number or percentage of patients on restricted antimicrobial agents. This is the percentage on restricted antimicrobial agent, and this is the percentage of on either watch or excess category of antimicrobial agents. And this is the number of patients on restricted antimicrobial agents stratified by indication type, means empirical based or evidence based therapy. And this is the data for number of patients or percentage of patient more than 3 antimicrobial agent for more than 3 days. And we have to correct all these parameters. If the patient is on more than 3 antimicrobial agent for more than 3 days, we have to analyze those data for those patients to lower down the percentage of antimicrobial agent for less than 3 days. Similarly, we have to collect the data for more than 3 antimicrobial agent for more than 7 days in case of critical conditions only. And so how this PPSC responsible for rational use of drug as well as prevention of antimicrobial resistance and reporting of ADR that we use. And this is all from my side. Thank you so much, sir.
Excellent delivery, ma'am, and particularly the de-escalation and escalation of the antimicrobials, particularly antibiotics, are the major concerns of WHO as well as various organizations working in the same field. Your lecture was highly motivating, and you have told ma'am a lot of things about PVPI as well as the clinical operations of NABH and various parameters into which the microbiology parts is one of the part which takes resistance. So antiretrovirals, antivirals, antimalarials, anti-sulfa, derivatives. and antibiotics. The World Health Report do also state this states. So fantastic presentation, ma'am. It was a ice-breaking session. I hope all the participants come to know the new dimension and an insightful story from the hospital arena, where in a real time you are working as a clinical research coordinator, and this antimicrobial stewardship is a major concern of the time. In
Yes.
21st century, these things are really remarkable. So I would like to thank you, ma'am. Your session was so wonderful, and I believe I have asked in the opening of the session to participants if any questions are there, they can write in the chat box. Since I haven't witnessed till now any question, it means the session was very awesome and wonderful. In spite of it, I would like to also request once more to all the participants if they have any kind of query, they can write in the chat box. And if yeah, so from Isaac Varghese, we have question that the infusion rates can affect ADR. So he's asking, can we explain about the infusion rate for antimicrobials in the practice?
Yes. In the normal practice, we have to very much focus on the infusion rate. Means there are regular lecture of all the staff members for particular infusion rate. If there is a decrease of drop rate, if there is an increase of drop rate, that is responsible for any of the ADR. As I already explained, the teicoplanin, that is responsible for red man syndrome. But in the actual practice, what we have observed, teicoplanin at a standard dose, it is responsible for red man syndrome. But the infusion rate has been decreased from 60 minutes to 30 minutes. It was responsible for severe tachycardia in one of our patients, and that is being observed during our root cause analysis. Means what was the standard dose, what is the means time of administration, and how you have administered that drug particularly. And during root cause analysis, what we have observed, that is the infusion rate from decreased from 60 minutes to 30 minutes. That is not responsible for itching, not responsible for Redman syndrome, means the whole body redness, but it is responsible for tachycardia. That is one of the our means real incident that I observed during my practice as a ADR reporting. Although they have reported as means a teicoplanin, it's a Redman syndrome that is already been established as a ADR for teicoplanin. But during the root cause analysis, what we have observed, that is not due, it is not due to the teicoplanin administration, means not due to the standard dose, not due to the drug only, it is due to the infusion rate, and it is not reported as a ADR, it is reported as a medication errors, particularly the administration errors. So if we are reporting any of the ADR related to any of the drug, firstly we have to go for root analysis. Means is it due to the drug only? Then we can report as a ADR. If it is related to the personal error, then we have to guide that particular person.
That's true. That's true.
Yeah.
Thank you, ma'am, for your answer. Uh, Any other questions? Yeah, I see only the box is full of the greetings and
Thank you,
that
sir.
is motivational session, ma'am, and a wonderful session and thought-provoking, nice lecture, and everyone is thankful. So thank you, ma'am. On behalf of ISF College of Pharmacy, Department of Pharmacy Practice, you touched upon all the major research areas of this antimicrobial stewardship as well as the practical concepts. And I wish that our 6 interns are working under you in PharmD, so they will learn
Yes,
this
yes.
all the things. And they are quite punctual and regular working in the same field. So thank you so
They
much,
are
ma'am.
means very hardworking. Means they are means very good work. Doing good.
And I hope and I, they continue striving hard for success and these practices are under your guidance.
So,
So thank you so much, ma'am. Once again, on behalf of ISF College of Pharmacy, Department of Pharmacy Practice, we, our team as AMC, are really thankful to you. You took out time from your really busy schedule. I know attending physicians and patients and the interns at the same time. So this schedule would have gone through various processes, and then you are here. So I'm thankful to you, ma'am, once again, and you are our proud alumni, and having your future sessions as well as in person, physically also would be
Thank you,
welcome.
sir. Thank you.
Thank you,
Thank you,
ma'am.
sir. Thank you, ISFCP family. Thank you.
Thank you, ma'am. Thank you so much, and thank you all the participants once again. And tomorrow is the last day of this our fifth National Pharmacovigilance Week. So we will have Dr. Rakesh Kumar Dikshit. He is a professor and head of medical pharmacology, King's George Medical University, Lucknow. So thank you so much, all of you, and this is all for the day. Thank you. Thank you, ma'am.
Thank you. Thank you.